بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أعزائي طلاب وطالبات المستوى الرابع ضمن برنامج بكالوريوس طب وجراحة الفم والأسنان، أهلا بكم في اللقاء العاشر ضمن لقاءاتنا التعليمية في مقرر طب الفم. في هذا اللقاء أيضا سنواصل الحديث عن the oral ulcerative lesions. We'll talk about part 3 oral ulcers. We had talking about the part 1 and part 2, and this is the part 3 of oral ulcers. In this video, in this lecture, we'll talk about the immune-mediated oral ulcerative lesions. The references, as we mentioned before, the Handbook of Oral Medicine and the Burkitt's Oral Medicine. Through this lecture and the end of this lecture, which will talk about the immune-mediated oral ulcerative lesions, the student at the end of this lecture should be able to perform a thorough examination of oral ulcerative lesions, reaching the final diagnosis and correlate the findings with the immune system status of the patient. And also the student should be able to diagnose the oral ulcers of immune-related origins and recognize their clinical features. Also the student should be able to recognize the types of immune-mediated oral ulcers and, as we mentioned, to correlate and interpret the systemic condition of the patient regarding the immune system and the oral ulcerative manifestations. At the end of this lecture also the student should be able to reach the final diagnosis and provide the patient with the best management procedures for the ulcerative lesions, and also should be able to refer the patient for the immunologist if he reached the final diagnosis regarding the immune system of the patient. In this lecture we will talk about 4 of immune-mediated oral ulcerative lesions, starting from Behçet disease, which is immunological conditions associated with ulcerative conditions in the oral, genital and the ocular organs. Also we'll talk about, through this lecture, about the oral erosive lichen planus as an ulcerative immune-mediated lesion, and also we'll talk about lichenoid reaction and graft-versus-host disease, all these 4 lesions as an ulcerative oral lesions. Of them may be a systemic condition with oral manifestations and may be just an oral existence. Starting with Behçet disease. Behçet disease is a systemic autoimmune disease. Its etiology and pathogenesis remains unclear, but there is known to be a relation with immune defects. Clinical feature of Behçet disease: multisystem condition, manifestations including oral and genital ulceration. So during taking the history of the patient, you should ask the patient if there is any ulcerative lesions in sites other than the oral cavity. And also the Behçet disease including arthritis and also vascular diseases and thrombophlebitis, as well as neurological diseases. Usually begins in the 3rd decade of life, when the patient age is at the 3rd decade, and is slightly more common in male than female. Clinically, it's more common in Mediterranean countries and in some Asian countries, especially Japan, as founded in the literature. The oral ulceration may be any of 3 forms of recurrent aphthous stomatitis, although the lesions tend to be major type, which heal with scarring as the major aphthous ulcer. How to differentiate? What are the similarities of Behçet disease? Differential diagnosis of Behçet disease: you should take into your consideration the age and the gender of the patient and the recurrence of the oral ulcers and also genital lesions, eye lesions, and Reiter syndrome should be also taken into consideration when diagnosing Behçet disease. Skin lesions also should be examined, arthritis as well as erythema multiforme, pemphigoid, pemphigus, herpes simplex, and syphilis, as well as the lupus erythematosus are the similarities of Behçet disease. So how you can diagnose the Behçet disease? The recurrent oral ulceration is an essential feature of Behçet disease. So the patient complaining from recurrent oral ulceration. Human leukocyte antigen typing may be value in diagnosing the Behçet disease, and there is a pathology test. After diagnosing the Behçet disease, you need to instruct the patient for the best management of this complaining. Oral lesion should be managed symptomatically, as we said for any other types of ulcers, in the same way as the recurrent ulcer and other types of ulcers. The systemic manifestations should be managed by the patient's physician, so you need to refer your patient to her physician or his physician to manage the systemic condition. The second immune-mediated ulcerative lesion is the erosive lichen planus. Erosive lichen planus can be caused by immune-mediated destruction of basal keratinocytes. One of the more prevalent mucocutaneous disorder is the erosive lichen planus, not known cause, and also more often immunologically mediated, and resembles in many ways the hypersensitivity reaction to unknown antigens. As we mentioned, T lymphocytes has been found to be cause for the destruction of basal keratinocytes, and leading to hyperkeratinization produces the characteristic clinical lesion of lichen planus. We will talk about it in the clinical feature. Drugs also and dental materials as well as graft-versus-Host disease can be associated with erosive lichen planus. Clinically, the lichen planus appears as white patches or stray that may affect the oral tissues at any oral site. The clinical appearance is variable, and the erosive form of the condition may produce the oral ulcer. So in the oral ulcerations we'll talk about the erosive lichen planus as an ulcerative lesion. Typically the erosive lichen planus bilateral and affect the buccal mucosa, most common site. Extraoral lesions. In the skin we can find rash characterized by lesions which are purple and pruritic itchy papules in the patient's skin, polygonal lesions, and also we can find in the flexor surface of the wrists and the lower back of the ankles and the chins. We will find these lesions. Extraoral lesions also, the trauma may induce new skin lesions. 10% of cases shedding or destruction of the nails, as we see in the last slide. Genital mucosa, we can find vulvovaginal gingival syndrome in about half of the reported patients with erosive lichen planus, and pinogingival syndrome is less common. Differential diagnosis of the erosive lichen planus, we can find other similar lesions such as speckled leukoplakia, which is the leukoplakia that has a white base with speckled with erythematous lesions. squamous cell carcinoma, which is an important and very dangerous, very invasive cancerous lesions of head and neck. Lichenoid drug reactions, which caused by drug reaction. Psoriasis also can be presented clinically similarly to the erosive lichen planus, stomatitis, areata migrans, as well as the atrophic candidiasis and discoid lupus erythematosus. All these should be differentiated from erosive lichen planus. Lichenoid reactions or lichenoid lesions that may need to be excluded: drug-induced lesions, dental material-induced lesions, diabetes mellitus, graft-versus-Host diseases, and also hepatic diseases or hepatitis C virus infections, as well as HIV infections. You should take these lesions into your consideration during differential diagnosis of the erosive lichen planus. The lichenoid lesions clinically resemble the lichen planus, but may be unilateral and may be associated with erosions, as well as may resolve in discontinuation of any offending drug. So how you can diagnose erosive lichen planus? The presence of cutaneous lesion as well as ulcerations. Further examination is likely to reveal areas with white patches or striae other than the oral mucosal site. So you need to find the white patch or white striae to reach the final diagnosis clinically. The firm diagnosis of lichen planus rely upon the biopsy and the histological examination. The definite precise diagnosis should be performed upon the histopathological test aided by direct immunostaining. So you need to take a biopsy from the erosive lesions and send it for the histopathologist to reveal if there is any histopathological changes or immune infiltration. The histopathological and immunological findings to exclude more dangerous conditions, and the management depends on the correction of the predisposing factors. The causes of the lichen planus should be stopped, removal of dental amalgams if it is related to the lesion, and the improvement of oral hygiene of the patient. In symptomatic cases, you need to prescribe an antiseptic mouthwashes such as a chlorhexidine mouthwash combined with topical steroids, either hydrocortisone hemisuccinate pellets 2 mg or by adding a betamethasone sodium phosphate 0.5 mg allowed to dissolve on the affected area 2 to 4 times daily. So this is the corticosteroid therapy used in adjunct of the antiseptic mouthwash to resolve the clinical symptoms. Topical steroid therapy also can be used, such as sprays or mouthwashes or creams and ointments, and this has been found to be effective for the patients. Intraoral lesional injections also can be used using triamcinolone, which is a type of corticosteroid. A short course of systemic steroid therapy may be required to alleviate acute symptoms if the patient complaining from acute severe ulcerative lesions. Systemic course of corticosteroid should be started. Cyclosporine mouthwash, topical tacrolimus, and systematic mycophenolate can be also prescribed for the patient. When the systemic administration of the corticosteroid must be continued for several weeks, as we know, these drugs can lead to complications such as diabetic diabetes and the hypertension. So the complications of the extended corticosteroid therapy should be considered. So you need to evaluate and monitor the patient random blood sugar or diabetes, as well as the hypertension status of the patient. So the corticosteroids, long-term use of corticosteroids should be monitored and evaluated for their complications. So the conclusion of erosive lichen planus as follow: the milder cases should be managed by the application of steroids such as flavonoid or Kinalog in oral base after meals and at the bedtime, so 4 times daily. This is the topical for milder cases. In severe cases, oral administration of adequate doses of prednisolone for 2 weeks. The lesions that are well into remission, the dosage of systemic corticosteroid may be tapered off and not to be stopped at one time. Small isolated lesions still persistent. If the small isolated lesions still persistent or present after the systemic treatment, the topical application can be helpful in these cases. Topical application of corticosteroid, of course, such as triamcinolone or Kinalog or whatever. The lichenoid reaction, which is resemble the lichen planus but differ from it by the cause. Systemic drugs, especially antihypertensives and hypoglycemics for diabetes, and non-steroidal anti-inflammatory agents as an analgesics have been implicated in lichenoid drug reactions. So the drugs which can be implicated or founded to be implicated in the development of lichenoid reactions are the antihypertensive drugs for treatment of hypertension and the hypoglycemics, which used for treatment of diabetic patient, as well as the non-steroidal anti-inflammatory drugs. These analgesics also have been implicated in the formation of or development of the lichenoid drug reaction. This is an expanded list of the drugs which can lead to lichenoid drug reactions. The non-steroidal anti-inflammatory drugs, as we mentioned, para-aminocyclic acids, penicillamine and penicillins, phenothiazines, and also propranolol. And this is the list of the drugs that can lead to lichenoid drug reactions, so should be taken into your consideration when taking the patient's history and especially the medical history. Clinically, there is a widespread irregular white patches. On occasions, the mucosa may be extensively ulcerated and sloughed. The differential diagnosis of lichenoid drug reactions should be differentiated from pemphigoid, erythromaltiform, leukoplakia, recurrent herpes simplex infections, as well as chronic pemphigus and lichen planus, and the acute necrotizing ulcerative gingivitis, as well as from the lupus erythematosus. Diagnosis of lichenoid drug reaction depends on the history of few week institution of drug therapy, be a connection for correlating this history from the clinical finding, and the mucosal biopsy is not helpful in supporting the diagnosis, so there is non-specific findings in the histological biopsy of lichenoid reaction lesions. The management so depends on the consideration that should be given to a chain of therapy to a structurally unrelated drug with similar therapeutic effect, so you need to refer the patient for his physician to replace the drug with the drug who has not reported to correlated or associated with lichenoid reaction. Resolution of the mucosal lesions usually follow within few weeks after changing the accused drug. Graft-versus-Host disease. Graft-versus-Host disease is a disease associated with an immune reaction related to graft as a response for host for this graft. Have received the etiology and the pathogenesis have received allogenic bone marrow transplantation, so your patient has a history of receiving bone marrow transplantation, form of a major blood or bone marrow abnormality such as leukemia, aplastic anemia, or widely disseminated malignancy. High dose of radiation and cytotoxic chemotherapy result in destruction of normal hematobiotic cells, and the human leukocytic antigen matching is not exact, then the engrafted lymphocytes targets the host cell. So the lymphocytes grafted will target the natural host cells, resulting in what we called it the graft-versus-host disease. Clinically, graft-versus-host diseases appear as acute phase at the next 100 days following the allogenic bone marrow transplantation, and there is a 50% of all bone marrow transplantation recipients will develop an acute graft-versus-host disease. Various skin rashes and blisters, vomiting, diarrhea, and liver dysfunctions can be also found in the patient with graft-versus-host disease cases. In chronic case of graft-versus-host disease, this occurred during the next 100 days following the bone marrow transplantation, which mimics the forms of autoimmune diseases. In the mouth, you will find white reticulated lesions that resemble erosive lichen planus, and burning of the mucosa secondary to the candidiasis and xerostomia associated with graft patient. The lesions which can be clinically similar to graft-versus-host disease is the oral lichen planus, erythema multiforme, Sjogren syndrome, so associated with dry mouth, and other associated clinical features. Systemic lupus erythematosus also can be differentiated from the graft-versus-host disease, as well as the radiation mucositis and neutropenia associated mucositis, and also the lichenoid drug reactions. All these lesions similarly clinically present as graft-versus-host disease. So how you can diagnose the graft-versus-host disease? The diagnosis in fact is challenging, particularly in the chronic stages of the disease, and which may resemble other diseases both clinically and microscopically, as we mentioned in the differential diagnosis. A clinical history from the patient is very important, coupled with oral lesions may lead one to suspect graft-versus-host disease. So you need to take an extensive detailed medical history from your patient. However, biopsy material is frequently non-specific, so we can not reach the final diagnosis by the biopsy, or may resemble the Lichen planus and lupus erythematosus. So the biopsy in diagnosing the graft-versus-host disease is non-specific method for diagnosis. Management of graft-versus-host disease. The most important management strategy is the prevention. So complete and detailed and accurate history and examination of the patient before the transplantation. Is the key treatment or the key prevention strategy for the developing the graft-versus-host disease. Careful human leukocyte antigen matching, as we mentioned, of bone marrow transplantation donor and recipient is important. Modulation of the immune response using immunosuppressive drugs after the transplantation. The patient should undergo the prescription of immune suppressive drugs such as cyclosporines, which reduce the immune response to the grafted tissue. Solan and ultraviolet A, helpful for cutaneous lesions, can be used for management of the skin lesions, and the suspected candidiasis should be treated for after microscopically diagnosed by systemic or topical antifungal drugs. Salivary substitutes such as the substitutes that found in the market for the Sjogren's syndrome patient or any patient complaining from dry mouth, and also topical anesthetic agents can be also beneficial. In conclusion, we had talking about patient disease, erosive lichen planus, lichenoid reaction, and graft-versus-host disease as an autoimmune diseases or immune-related ulcerative, immune-mediated ulcerative lesions. In this lecture, we finished the oral ulcerative lesions as a part of the curriculum, speaking about the part 1 and the part 2 and the part 3 of oral ulcers. The assignment of this lecture is the clinical presentations of cases complaining from any type of immune-mediated ulcers, and this assignment also will be provided in the assignment section of the course as an attached Word document titled Assignment 10 for the 10th lecture. Thank you very much, dear students, for your listening and your interesting.